Good day, my dear postgraduate students. Welcome to SNIP, Short Notes in Pathology. And the topics that I have taken are either nesidioblastosis or nesidoblastoma. Any of this can be a question, and let us see in what way we can answer. The terms. There is a focal or a diffuse alteration in the neuroendocrine compartment of the pancreas. So it can be the islet cells and so on. And it presents with hyperinsulinemic hypoglycemia. Whenever the insulin is increased, there is a hypoglycemia. And also you find that there can be microscopic lesions which can correlate with hypoglycemia. So this is a picture. You find the loop of the duodenum and the head of the pancreas snugly fitting in. There is also a lesion. Well defined, it can be an insulinoma thanks to Cleveland Clinic. The terminology is associated with functional disorders of the B cells. And sometimes it can be in the absence of an insulinoma or sometimes it can be present. The etiopathogenesis, mainly remember this, there is an abnormality in the potassium channels or the calcium channels due to mutation. So this is the basic abnormality. And thanks to this particular reference, you find that it can affect the fetus most. So there is a bloated child and that is having a Cushingoid features. There can be other clinical presentations such as neonatal hypoglycemia, adrenergic signs such as trembling, sweating, palpitation, tachycardia, or neurogenic such as dizziness, aphasia, as well as behavioral changes. These can be present. And the clinical thing continues. Less than 3 years of age, females more prone than males. And the etiology, it is because of congenital heterozygosity, mostly maternal in origin. And there is a chromosome that is affected. Adults, the genetic is very rare and it can be partially due to a gastrectomy or a surgery for obesity leading to endocrine imbalances. The clinical features we had already seen. There can be sweating or palpitation, abdominal pain, aphasia, and lethargy. Cushing's obviously will be having all this. Asymptomatic or non-functional can also be there, so we should be careful with the diagnosis. And it is also important for treatment. Nesidoblastoma, which indicates a tumor as such. So in this case, I am finding a well-defined tumor that is circumscribed, having a cystic change that is shown in the CT scan also. And it can be non-functional. And these are all the features of it. Kindly go through. Pathogenesis. Here, there are two cells actually, probably the islet cells, and there is a nucleus, a cytoplasm. In both of them, you find that there is a glucose entering, the glucokinase is an enzyme. G6-phosphate is also being used for the production of energy, ATP, ADP, etc. So, in one case, it is normal, and a normal amount of insulin is being produced, and the blood sugar is normal. Whereas, in another case, either due to genetic abnormality, there can be a mutation in the glucokinase gene, or there can be an increased production of glucose 6-phosphate, leading to an increased activation of ATP and ADP, and this activates the calcium channels, opens up all this, as a result of which more of this insulin is being produced, leading to hypoglycemia. I think this picture will be apt. At least one of this you can draw. And what are the differences between nesidioblastosis and nesidioblastoma or insulinoma? Obviously, oma means a tumor. Both of them are benign conditions. So, you can diagnose them by means of a postprandial and there will be a hypoglycemia that is diagnosed. Age is neonate, insulinoma in adults. Both are benign. Genetic in the case of nesidioblastosis. In insulinoma, it can be sporadic but associated with MEN1. Insulin C peptide is high in both. In gross, you find that there is a non-specific but a diffuse lesion in nesidioblastosis, whereas it is solitary and well circumscribed in a case of nesidioblastoma. Microscopically, similarly, as you are seeing in this picture, all these pale cells are the islet cells and they are seen diffusely through. Hypertrophied B cell as well as giant nuclei can be seen, whereas here there are giant nuclei, amyloid deposition can also be present. The treatment can be medical or surgical, and a partial pancreatectomy is advised in a case of insulinoma. This particular table will help you answer the question. And nesidioblastosis, as I had been explaining, these are all the islet cells. There is an increase in the size. They are diffusely spaced. There can be some amount of nuclear pleomorphism. Macronucleoli can be seen. And the insulinoma has to be excluded by means of IHC. Orthotopic or heterotopic, present within the pancreas, or heterotropic pancreatic parenchyma. So this is nesidioblastosis. A line diagram like this will help. And look at this one. This is what I meant. I find that there is some amount of pleomorphism. The nuclei are also large. We call it as giant nuclei. And the pattern, it can be either in the form of a well circumscribed islet, or it can be in the form of ribbons or a gyriform pattern. Amyloid deposition can be there thanks to basic medical key. And it is associated with the MEN1 syndrome, which can be hypothyroidism, hypoparathyroidism, pituitary adenoma, and an insulinoma. Look at the giant cells over here. Courtesy Shutterstock. The diagnosis is by hypoglycemia, ruling out the other causes, the fasting blood sugar. And the differential diagnosis can be the paraneoplastic syndrome such as Doege border syndrome. I do not know what it is, but then you will have to mention it. Pituitary adrenal insufficiency and history of a bypass surgery. All these will have to be taken into account. The treatment is low carbohydrates, glucocorticoids, and the surgery, biopsy or treatment wise.